Good morning, everyone. I'm David Young, and I have the honor of managing sales for the Southeast, which includes states from Virginia to Florida. And of course, we do things outside of those areas, but we're excited to be talking to our Southeast partners today. Let me just give you a brief overview of what's going to happen. We are recording this so that you'll have a recording. You can share it with others after the meeting today. We'll share it with you. You can share it with some of your team members. So let me give you a brief overview of the agenda that we're going to cover today. Thanks, Ashley. Obviously, just a kickoff, we're going to hear from Jeff Wells, our CEO, and I think that'll be fascinating for you. Our Chief Health Officer, Nirav Vakharia, will be joining us to talk about our care model, while members from our Southeast team to talk a little bit about our model and some new services there. And last but not least, Krista Beckwith will be on to talk about some new and enhanced services, including some of those services that you're getting asked about quite often, GLP-1s and other services. So we think it's going to be we think it'll be informative for you. We do have at the end of this a Q&A time. We're going to leave some time for question and answers. If you'll just do that question and answer in the Q&A section, then we'll go through those at the end of our presentation. With that, we want to start off with a poll just to get everyone awake and going. And we'll show you that poll and you can see it on your screen now. If you'll just do a quick answer on that. Just a few minutes. Thank you for answering. Just a few more people need to respond. We're at 68%, though. That's good. If you're just joining us, you'll see a poll. This is the way we're starting out, just to get your mind going this morning. Okay. You see that Jeff, you see the most folks say between 17% and 33%. So I'm going to turn it over to you and let you answer that question for them. How much savings do you think that integrating the right kind of primary care services can typically achieve?
Well, thanks, David. And thanks to so many for carving out a little bit of your time today to spend with us on what we think is a really important opportunity in face of so many challenges, with respect to health and healthcare across the country. So the correct answer was 33%. There's actually a number of studies that validate that. So I appreciate everybody from responding. Just by way of brief introduction and background, again, my name is Jeff Wells, and I serve as our Chief Executive Officer, also a founder of the organization. I've been doing this work for just over 15 years. Based in Indianapolis, Indiana, but spend a good amount of time not only throughout the Southeast, but all over the U.S. I'm a primary care physician by training. So grew up with a real passion to want to serve, to want to go into healthcare and partner with patients in a really holistic manner. And as I was going through training, my own personal experience, I found myself kind of running, directly into a broken healthcare system. And so my professional life has really been inspired by a desire to really bring joy and meaning back to the purpose of medicine and to work really diligently to try to make healthcare work for patients. And with that, would love to share a little bit more about our organization and what inspires us and what we do and a little bit of why. Maybe I would lead with a slightly provocative recommendation, but I think the data will back this up. If you as consultants were to do only one thing in 2025 for the clients that you work with, I would strongly encourage you to increase the quality and the quantity of primary care available to the employees and family members of those organizations. We're going to talk specifically about the right type of primary care that we'll refer to as advanced primary care. But again, if there were only one new initiative or one priority that you moved forward, I am convinced that you'll see stronger, more sustainable, and better results in terms of the key problems you're trying to solve. Let me set a little bit of context. Over the last 3 to 4 decades, we've seen the culture of American health and well-being decline. This is really a societal challenge. There are multiple complex factors that drive that. We've certainly seen a material change in the nature of work, moving away from sort of agriculture and industrial work where people are very active to many jobs that are much more sedentary. And, the development of technology, again, that pervades our society where we're generally less active at baseline. We've seen certainly a shift in change in the nature of food and nutrition to become, maybe more of a priority around convenience and therefore a bit of an industrialization or commercialization of our food supply. And when you add all these things up, it's not shocking that we see a really high prevalence of chronic conditions that negatively impact health and well-being, and really both the quality and quantity of life. Over half of Americans have a chronic condition, and 15 of those conditions, things like cardiovascular risk and diabetes, obesity, musculoskeletal challenges like chronic low back pain and arthritis, neurodegenerative disorders, mental health challenges like anxiety and depression, make up these chronic conditions that really drive over 85% of all cost. And for all of you that are very sophisticated and work so closely, you'll consistently see in your data that a sort of small percentage of individuals disproportionately drive a high percentage of cost. If I asked how the traditional healthcare system and traditional healthcare providers are doing today and really over the last few decades at addressing that underlying challenge, the only honest answer would be a failing grade. Consistently across the US, we see our healthcare system provide unreliable care. There's a high degree of misuse, of overuse. We have procedures that don't have any evidence that are routinely done and can expose patients to harm. We see medications that are overprescribed, again, to the wrong patients or at the wrong dose or when they're just not needed. And we see consistently really proven care, whether it's good screening, good prevention, or really high-value care that often just isn't done for one reason or another. You couple that with what I would call a market failure, where we have crazy price variation. And the same service in the same town, even with the same insurance network across a couple different providers, can range by hundreds of percent. A simple example, if you need an imaging study, let's say an MRI of your back, in one health system, it may cost $2,000 or $3,000. And if that patient were just to go across town to a different provider, maybe an independent radiology group, the same exact thing with no change in quality could cost as low as $500 or $600. We see that consistently, whether it's the cost of medications, the cost of procedures, the cost of office visits or hospitalizations. It's just candidly a market failure. What we do know is that there is an answer to all of those challenges. We do know that primary care works. As the poll highlighted, published studies have shown, going back 50 plus years in the United States and in other developed countries, that primary care, when a patient is connected to a true primary care partner in a team, cost is on average 33% lower, and that individual patient has a 19% lower risk of death. But in the US, we only have half the primary care providers per 100,000 people compared to other developed countries. And furthermore, the primary care that we do have is almost always part of a large integrated health system that's being paid in a traditional fee-for-service manner. That becomes rushed. There's a focus on volume, and it really degrades the opportunity that we have for those patients. What we really need is more advanced primary care. What is advanced primary care? I would tell you simply, it includes two things. you need the right care model and the right financial model to support that. The right care model needs three things: a real proactive focus on population health. So you think about a primary care team that is incentivized to reach out proactively, to use data, to anticipate, to drive engagement, and not just wait for people to get sick or break. It needs more time with that provider and the patient, with a real focus on holistic care, relationship-based care, and a focus on positive behavior change. And three, it needs a real integrated focus on managing high-value specialty or complex care when needed. So think about the right type of care navigation so that that trusted primary care team can avoid referrals that aren't necessary and get people to high-value specialists when it is necessary. All of this can be enabled with the right financial model. Think about a value-based payment, not a fee-for-service-based payment system. And it can come in a number of forms. It could be subscription-based or fixed fee-based. There can be performance guarantees built in, but you really want that to be a value-based reimbursement model to enable that care model that works. If we flip forward, Marathon Health has been designed to do just that. And going back to our founding in 2005, and over time, Marathon Health has really brought together some of the best and brightest entrepreneurs and founding teams with advanced primary care models, serving employers and labor organizations and increasingly commercial health plans across the country. And over that time, we've always been really purpose-driven. So our team gets out of bed in the morning with energy, with excitement to enable millions of people to live their healthiest life, one patient at a time. And I think that's a call to action that we want to make change at scale and really transform the way healthcare works across the country. But there is not one recipe. Every unique individual patient has a story, and the only way we can be successful is as a team embedded with how we think about the human experience, as well as the digital or technology experience, that it is highly personalized for each individual that we have the opportunity to serve. We're an outcomes-driven organization and really build everything about our model on the quadruple aim. So it all starts with our own people. If we can empower, especially our frontline clinical care teams, and create a fantastic environment where they want to stay and build a career, that's going to unlock a better patient experience to drive more access, more engagement, and ultimately better outcomes. I'm really proud to say that over 90% of our providers are retained. And this has been a consistent metric going back 10, 15 years plus, even through challenging environments like the pandemic. Right now, our physicians and advanced practice providers have 93% trailing 12-month retention. That leads to really impressive engagement of patients. So our top quartile of clients, we see 73% engagement across the whole book of business, over 40% for all eligible members, and over 50% of high-risk members. 2/3 of those engaged with us see improved health risk management and better health outcomes when you look at quality of care and control of chronic conditions. And on average, an engaged patient costs $1,800 less. We're really proud that we have a national presence, and for national or really large regional employer or labor organizations gives us the ability to show up where they need us as a great partner. But ultimately, and at the end of the day, healthcare is local. And so you'll see a really big part of our strategy is to go deep in regional and in local markets to really invest more resources and build out our capability. We know that that makes us better. It drives a better experience for our own clinical teams and better support talent and staffing and know-how. It allows us to show up with more access and a better experience for patients, and ultimately to drive better partnership and outcomes for the client partners that we work with. You can see the statistics on the slide. We work with about 650 and growing employer or labor organizations. We operate over 720 physical primary care health centers. We serve about 3 million patients. And what I'm really proud to say is we have 96% client retention, and it ranges, I'd say, from the low of 95 to 98% client retention year after year after year, going back almost 20 years. We've been recognized the last 6 years in a row by the KLAS organization as the leader in this category of employer-sponsored healthcare services. And I think that's a real testament to the type of partnership that we invest in. And if you were to ask me, among all of the organizations that an organization could partner with in an advanced primary care model, like why Marathon Health, I would emphasize four key reasons. The first would be unmatched access. We're going to talk a little bit more about this, but across those 720 physical health centers, we have a few different models and ways that we can show up to meet patients where they are and to meet the needs of different organizations, whether they're in urban versus rural environments, highly distributed versus centralized. We have both in-person and virtual care that we'll touch on, in both dedicated sites, kind of in partnership with a single client, as well as shared access across over 100 locations throughout the US that we'll touch on. The second would be to really maximize downstream savings. The most important pain point that our clients are telling us today and prospective new partners is the cost of care. We've invested a lot in our care navigation offerings. And so we'll touch a little bit on some of the tools that we have available to help do e-consults to avoid referrals when they're not needed, just really good primary care delivery so we can spend time with patients, and a dedicated value-based referral guidance solution with both people and technology to drive more savings and better outcomes for referrals. The third would be a whole health care model, a really integrated one with a comprehensive set of services. Other members of our team are going to touch a little bit more on that, but it's a really holistic model. And I think employers increasingly want to move away from point solutions to really an integrated model and more of a platform. And I think we can bring that with a lot of our own capabilities and also very comfortable integrating and partnering with other capable point solutions, but in a more integrated, seamless way for both the patient journey and to make life easier for the client. And finally, I think just highlighting, we're really recognized as a strategic partner. And so that KLAS recognition to me is not an accident. If you ask our clients, what makes Marathon Health a good partner, it's that we really seek for this to be a partner, not a vendor relationship. And so sort of authentic investment in the relationship, being proactive, intentional, transparent, and honest, owning our mistakes, like when we're not providing the kind of service that we should, taking ownership of that and fixing it, really trying to provide good data and insight, and just being highly adaptable and flexible to sort of meet the needs of a really diverse client base. And so with that, I will transition it back to David to introduce the rest of the team, and just really appreciate your guys' time and attention today. So thanks so much.
Jeff, thank you. That was excellent. We get asked all the time of what makes you unique or what makes you different. There are other folks in this space, and I thought you summarized that very nicely. Again, I'm David Young. I think one of the things you'll see with our Southeast team is that we have a lot of tenure. I'm blessed to be able to work with such great people. I've been doing this for over 14 years now and love trying to help our mutual clients save money and offer a unbelievable benefit to their employees and family members. Shannon Mason is in Florida, and she covers our Florida market. Nick Simoff is in Richmond, Virginia. He covers the Richmond network as well as other areas in Virginia. Sarah Van Kampen she's kind of a catch-all. She's in Atlanta, but you'll see her working in North Carolina and a little bit in Florida with Shannon, all over. So we're fortunate to have that tenure person. Ashley Smith, I skipped over her on purpose, but she's kind of the glue that holds all of us together. And she takes care of a lot of our needs, but also you may see her on some calls or interact with her as she helps us to do a better job of providing the right solution for you and your clients. And lastly, we have a new member joining, Meredith Lewis. She's been in this space for a while. She's coming back to focus on our Charlotte network, and she actually starts on Monday. But we put her on, and we wanted you to see her, and we're excited about about her joining our Southeast team. So that's your Southeast team. Where again, I think you are in good hands if you're interested in talking to one of us about a health solution for your a health center solution for your clients. So with that, I am going to turn it over to Shannon to talk about some of our networks that I talked about.
Thank you, David. I appreciate that. As David said, I'm Shannon Mason. I am a vice president of the Southeast. I am located down here in sunny Orlando, Florida. And I'm sure many of you I've worked with in the past and look forward to working with you in the future. You can see on our slide here, I wanted to talk a few minutes today about what our geographic footprint looks like here in the Southeast and the type of clients that we serve. And as I was looking at the slide, I even realized there are some areas like our Mississippi and Alabama. Well, we have Alabama on there, but there are some other areas that we might even consider to be the Southeast, but just aren't clearly listed here on this slide. What I wanted to make sure you understood today is that we have such a comprehensive area served throughout the Southeast. We have about 102 clients there and 206 centers. Often people say, well, what's the difference? And sometimes a center is shared by more than one entity, and sometimes a client may have more than one health center. So that would be why some of those numbers are a little bit different. You can also see that we have 663 teammates throughout the region. That gives us a lot of economies of scale. And we also serve 400,000 patients. One thing I wanted to point out to you on the slide is the type of industries that we also serve. That's a common question that's asked of us. We serve in the public sector quite often. So those would be cities, counties, schools, and so forth. We also have quite a few in the manufacturing sector, and we have a few listed, also financial and insurance services. And last but not least, you probably see these logos here on our slide that are prominent in different areas. We have some shared open network health centers in Charlotte, North Carolina, Richmond, Virginia, and also down here in my area in Orlando, Florida. So those are open for more than one employer to be able to use those. And I'm going to transition here in a second over to Nick, and Nick is going to get a little deeper into the different access points and channels and methods of health centers that we serve. So over to you, Nick.
Thanks, Shannon. As David mentioned, my name is Nick Simoff. I'm based in Richmond, Virginia, and cover all of our growth efforts here in Virginia. And as Shannon mentioned, we have a lot of different ways in which care can be delivered. And that avenue for care really depends on the individual client. And what I'd like to point out, whether it's the 720 plus locations we have nationwide, or the 200 plus locations we have here in the Southeast, our first way we deliver care is in what we call a partnership location. And that's your traditional employer on-site health center where you have a large centralized workforce in one space. And that client really gets to dictate what type of services are provided in that space. In this setup, typically there's going to be some capital costs for the employer from a build out standpoint. But we have other ways that we can mitigate that in different care delivery models. The next one is what we call hub and spoke. Typically that's a couple employers in a geographic location where there's a larger employer that holds the governance and creates the structure of what's provided in that health center, and then smaller local employers then pay for access into that hub location. So this is mid-size to large workforces in a smaller market that maybe don't have space for an on-site in their workplace. The next one, and Shannon mentioned this, is what we call our network health centers. These are freestanding health centers built in a metropolitan area where multiple employers can access care in these health centers. The great thing about this is that we build them as Marathon Health, and the employers, our clients, don't have any build out or capital costs. They're purely paying for access into those network health centers. And this is great for highly distributed workforces in a metropolitan area, and even small workforces that traditionally wouldn't be able to pay for that on-site health center or have the space or capital for a smaller workforce. The last thing here is we have a virtual advanced primary care and acute care in all 50 states. And this is all with Marathon Health professionals. And so this is great for when maybe you have a client that has their own health center or accesses a network, but then has a percentage of their workforce that's outside of an easily drivable area. They can still access that great advanced primary care and acute care virtually. And it's a great way to make sure there's continuity of benefits for an entire population. I'm going to pass it over to Sarah Van Camp, and she's going to talk about how all the different services that we provide can be delivered in each of these settings.
Thank you, Nick. Good morning, everyone. Like Nick said, my name is Sarah Van Camp. I'm really excited to virtually introduce myself to you all, to those that I haven't had the chance to meet. Before we get to Dr. Vakarian and his opportunity to introduce himself and his role, we wanted to just quickly kind of close out this first section of who Marathon Health is and what we're rooted in, with a reminder of our core scope of services, as well as the services that we're delivering in our health centers across the country. As a business, and Jeff alluded to this throughout the beginning here, we're deeply rooted in primary and preventive care services. That continues to be the heartbeat of our organization. It's where we're starting to build our solutions alongside our partners today and into the future. So on the left there, in that kind of green circle that you'll see, that goes into what is included in that advanced primary care core. It's more than just primary care or even primary care plus that you'll see, but it includes things like specialty e-consults and referral services that Jeff had mentioned. We want to deliver as much care within the figurative four walls of our health center as we can. But when needs arise that are outside of that, we want to be an advocate for our patients throughout their journey. And so by both providing that concierge referral services when it needs to go outside, but also giving our providers the chance to have specialty e-consult resources at their fingertips to ensure the patients are getting the care they need, whether that be inside or outside of our health centers. On the right here in purple, you'll also see the additional kind of ancillary service offerings that we're delivering in health centers across the country. These, as many of you know, can either be added at the beginning of a health center relationship based on their goals and objectives, or throughout the length of our time together. Ultimately, the solution is built around those client needs and the goals that they're trying to accomplish. This includes things like occupational health, physical therapy, mental health services, and more throughout there. The key to being able to offer these ancillary services, because we know many of these clients may have a portion of this delivered in different ways in their benefit offering today, is allowing it to be an integrated service with our core service offerings. So allowing for that warm handoff between the physical therapist and the primary care, allowing the chance for there to be different touch points for patients to get into the health center and build that long-term relationship and integrated care model. There's a lot more we could dive into there, but I want to give the chance for Dr. Vakarian to jump in and share a little bit more about his role as our Chief Health Officer and the direction that we're headed as a business.
Thank you, Sarah. Good morning, everyone. You all may be in the Southeast, but I'm in the Midwest, speaking to you from Cleveland, Ohio. I'm a practicing primary care physician. I've been in practice for almost 20 years. And excited today to talk to you about our care model, which, if the term is not familiar to you, I'd encourage you to sort of think back to the slide Sarah did, and all of those different services are ingredients. Those ingredients are for a recipe where we organize and sequence the mixture and the processing of those ingredients to make sure we're driving the right outcomes for our clients. And so I'll talk a little bit about our care model today, as well as where it's going. Go to the next slide, please. As I mentioned, I'm a practicing PCP. I also used to be a middle school teacher. And in both of those experiences, I came to learn firsthand how important it is to think about the whole person that's in front of you, whether it's in the classroom or in the exam room, and not necessarily just the symptom or just the objective of the day. People bring in to those respective rooms issues from their own personal life, from their family life, from their jobs, and it's really important that we keep those in context. And so for that reason, intentionally, we don't have a chief medical officer. And that's not just because we don't want to confuse the CMO role with the chief marketing officer, but rather it's because it really reflects the more expansive view we take and how we program our care model to be thinking about the broader drivers of a patient and a population's health outcomes. So what we try to really think about is, as our purpose was covered earlier, we believe absolutely this is the right model to improve outcomes at scale, but also that we have to personalize that through the time that we spend understanding our patients and through the data that we use to really help drive that personalization. If you can go to the next slide, please. I think we've established, and you all answered correctly, the value of primary care. And I'm going to echo the public service announcement that Jeff made earlier, that if there's one place where you encourage your clients to spend their precious healthcare resources, it's to improve access to primary care, period. Of course, we believe that advanced primary care, as we practice, is the right place to distribute that. But access to any primary care for over 50 years, study after study after study, has conclusively and repetitively proven that it improves outcomes. Patients feel better. Health outcomes, the hard outcomes improve. They stay out of the hospital and other high-cost settings more. And it saves lives. It extends longevity just by having access to it. And this is even just the sort of more traditional, these studies were based on the more traditional offerings of primary care. Imagine what it means when you have the additional services that you would get in an advanced primary care setting. If we can go to the next slide, please. So in our model, which we've covered a little bit and we're going to cover some more, it only works when people use it. And not just use it once, but keep using it. And what we look to see as a leading indicator of those more beneficial downstream outcomes is both initial engagement as well as engagement intensity. How often are we interacting with patients? And since they're never mandated to come see us, what we have to rely on is the trust that we build with our patients. So that is our primary KPI, is what trust do we build with our patients and by extension, our clients. Study after study, both in primary care and more broadly, say that trust is primarily driven by answering the question, are you there when I need you? And are you there increasingly in a multimodal manner? Used to be you had to literally walk in the front door, but now you can click in through a portal. And increasingly, as we'll talk about in a moment, you can engage with us in a variety of other ways to make sure that accessibility is always available in order to drive that trust. And when you've got millions of people who are eligible for your services, in addition to always making sure the lights are on and the doors are open, we also have an opportunity to use the data that's provided, specifically historical claims data, to start to winnow that down to who are the patients most in need and how do we do more proactive outreach and build trust with those patients selectively so that we can get them access to the care they need and perhaps even have wanted, and as a result, have a greater opportunity to drive outcomes for their employers. Go to the next slide, please. So what you see here is a schematic of the flow of a patient through our system or the broader healthcare ecosystem, if using Marathon Health as their advanced care primary care provider, as well as the flow of their data. But what I'd like to really focus on is a couple of things that aren't necessarily on the slide. The first is if you take that sort of big green circle in the middle, which is essentially what is the secret sauce of Marathon Health? What do we do in terms of our advanced primary care model? Our strategic goal as we evolve our care model is to make that bigger and bigger, to have more opportunity to take care of the healthcare needs and wants of populations within our four walls, because that brings the convenience of access, that brings the integration of their data. And there are wonderful examples where clients themselves have really pushed us to evolve our care model. Later today, we'll talk about how we recognize that specialty pharmacy management is an increasing issue. And Krista will talk about how it's really clients raising their hands and saying, what can Marathon do to help me with this? That's leading to some really great interventions that satisfy patients as well as their clients. Another would be the integration of occupational health. We know that oftentimes employers are on the hook for both the medical spend as well as the workers' compensation spend. And having that be an integrated solution that also can be kept in-house allows us to really make sure we're focusing on the patient at the middle of this equation, and how do we drive their care forward in a way that's aligned with the business's goals, and not necessarily have that patient go out to the community where you may not have as much opportunity to influence the patterns of care there. The second takeaway from the slide is how it's important to recognize that for this to really work, the employer needs to recognize that the advanced primary care solution is an important portal into the broader ecosystem. We succeed best and clients succeed best in terms of reaching their goals around outcomes and cost when they recognize that this isn't just another solution, but it is one of the more important solutions to drive access through, because that allows us to orchestrate the very complex supply chain of other solutions, point solutions that employers might have, and make sure that patients are getting the right service at the right time, while also making sure we're rationalizing the use of healthcare resources. And Krista is also going to cover that in a little bit more detail. I'd like to close with just a couple of things. Next slide, please. One is an example that's from your backyard, Mecklenburg County, just to bring some more detail to the story and how it all fits together. Mecklenburg County in North Carolina, the Charlotte area, signed up with Marathon Health about 6 years ago to access the 6 local already established network health centers, in addition to our 50-state virtual care primary care practice. And what was really remarkable about this partnership is how important the leaders at Mecklenburg County realized it was important to drive engagement of primary care for them to achieve their downstream goals. In particular, how they organized their wellness incentive to drive engagement. And in the first year, we saw over 30% of their employees engage with us. And when they did engage, they had such a good experience, they kept coming back. And last year, we hit 72% engagement of their employees with our providers, and overall eligibles were above 45% engaged with our providers. And that engagement is that leading indicator that I described earlier. What comes downstream is the result of better clinical care, more focus on lifestyle and coaching, so patients master the knowledge, the skills, the confidence they need to manage their own health conditions. And then you start to see the hard clinical outcomes improve, whether it's smoking rates, whether it was diabetes control, which doubled during our engagement with them, whether it's hypertension control, which also doubled during our time with them, or it's looking at where healthcare was being utilized, and specifically the lowering of ER utilization by 22% or inpatient utilization by 50%. And as the years go on and the population is reprogrammed to utilize healthcare in this different way and come to Marathon first, instead of going out and being lost in the community, what we also experienced overall in terms of their book of business was an average of 1.5% annual growth in their healthcare expenditures, when the rest of the market grew at between 6 and 8%. And the increasing spread of that line drove positive ROI, which continues to this day. What's great about this, a couple of things just in terms of Mecklenburg County being such a wonderful client partner, is that number one, they recognized their role in driving engagement. And number two, they recognize these things take time. Rome was not built in a day, nor will the outcomes of 10,000 people improve in a day. And so having that multi-year view and really being partners at the table is what allows us to tell this wonderful story. Finally, let me close with just a little bit on where we're going next. As I said before, you used to have to walk in the front door. Today, you get to click in, you get to use a portal to engage with your provider, you get to soon use text message to make it even easier, and other asynchronous modalities that make it convenient for employees so that they don't have to take time off work. They can engage on the weekend, they can engage at nights, whatever it makes sense for them. This is, of course, the age of AI, and we are very excited to understand what is the thoughtful, purposeful, and rational use of AI as we bring it into healthcare. And so what we're piloting this year are various clinical decision support tools that provide that nudge or that suggestion right at the point of care in the electronic health record and the flow of a visit to really help that provider make the right evidence-based decision for their patients and continue to focus on quality improvement. And then finally, and I'll just do a preview on this because Krista will talk more in a moment. Historically, what we've done is really try to make sure we get our patients to the right community destination if and when they need to leave for specialty care or procedural care, using Garner Analytics to make sure that we help navigate patients to the highest value destination. Increasingly, we have opportunities to build tighter connections with key high-value providers in the community, and that's something we'd like to cover in our next section. So thanks for this opportunity, and Krista, turning it over to you.
Thanks, Rob. Good morning, everyone. My name is Krista Beckwith, and I'm the Vice President of Population Health at Marathon Health. I have the opportunity to wear a couple of different leadership hats in the company, including product leadership over our wellness, population health, and navigation products. Additionally, I get to have the operations leadership as well over many of those products that are sold under that same umbrella. I'm thrilled to be with you all today discussing both where Marathon Health is going with our strategic roadmap, as well as taking a deep dive into a few areas we are actively rolling out. As we move to the next slide, Marathon Health continues to have a strategic focus in bending the cost curve. That's including what may happen outside the four walls of primary care. Our ability to impact total cost of care really starts with our advanced primary care model, as articulated by both Jeff and Nirav. And our strategic roadmap is really focused on deepening and expanding that key model and impact that we have. We see our strategic roadmap really falling into 4 buckets. If you start on the left, driving downstream cost savings. Again, really focusing on how we impact what happens outside the 4 walls of primary care and how to achieve optimal financial and clinical outcomes in the larger healthcare ecosystem. Taking a step to the right, strengthening our engagement levers, really deepening our ability to engage populations into advanced primary care, further solidifying that anchoring relationship between the Marathon Health primary care provider and the patient. Another step to the right, expanding our service offerings, continuing to iterate on the types and modalities of offerings that can be integrated within a Marathon Health primary care setting. We know we can drive total cost of care savings when we further bring integration to the patient within the primary care setting versus having that patient exit the primary care setting to offer and access different point solutions. And then on the far right, deepening our integration with benefit design, recognizing we are one component of a larger benefit ecosystem, and really looking at how we can intensify our ability to support our clients with how that system is orchestrated and our role within it. Within these 4 buckets, we have initiatives at various points of execution, from exploration and ideation to pilot to being in full execution mode with enhancements underway. A couple of examples on the spectrum include our multimodal asynchronous care. Nirav touched on this. Everything from AI-based diagnosis tools to having an e-visit with a patient that is then reviewed and finalized by a provider. Really allowing low acuity visits to become more accessible and freeing up provider time to focus on that higher cost patient. We now have multiple generations in the workforce and multiple generations accessing healthcare services. And those populations all want healthcare delivered in a different way, including technology. And so this allows us to bring technology to the forefront as part of how we are really serving populations who look for that as part of their healthcare experience. For us, this is really an area of exploration and ideation, and we're super excited to see where it takes us. Another example is our virtual musculoskeletal asynchronous and live initiative, the ability to provide asynchronous care with the patient between those face-to-face visits that occur with the PT, where the patient can upload results and have that reviewed by the PT, again, deepening that relationship in between the visits that are face-to-face. We are in pilot phase in this initiative with our partner, MedBridge Pathways. And then on the far left, social determinants of health management and community referral initiative, creating a more standardized, deliberate approach to SDOH screening within our EMR system that results in a more comprehensive screening initiative across our populations and a standardized way for our providers to really focus on that total impact, because we recognize that oftentimes what impacts the ability to achieve health are things that fall outside the traditional healthcare system. I'd now like to take a deeper dive into a couple of areas on our roadmap. And so as we move to this next slide, we have found some exciting opportunities and really common areas of interest and demand among our client base. That includes specialty care navigation and our GLP-1 utilization management program. As illustrated on the slide, you'll see each of these areas in different states of operations and strategy execution. Within our specialty care navigation domain, we are continuing to expand on our comprehensive approach through building out partnerships and integration opportunities for those custom specialty networks and direct contracting initiatives. And as we look at our GLP-1 solution, we see that this is actually newly launched for us in our market and with our clients, and we are already scoping out future iterations of it. Let's move to the next slide and dive deeper into our specialty care navigation. This has been hit on by multiple members of the Marathon Health team. At Marathon Health, we play an active role in really orchestrating what can and should happen outside of primary care. And our ability to address downstream care requires a comprehensive approach of solutions that really reflect the variations that may occur with a patient coming into our health center. Beginning on the left, we really focus on first avoiding specialist referrals where feasible. In providing advanced primary care, we're able to address upwards of 90% of a patient's needs within the four walls of Marathon Health. Part of our ability to do that includes using our partnership with RubiconMD, where our providers are able to complete an e-consult or peer-to-peer consult with a specialist on a patient's care plan while keeping that patient in primary care. This means that when I show up to my Marathon Health provider's office and I've got a weird rash on my arm or a suspicious mole, rather than immediately referring me out to dermatology, my Marathon Health provider can take a picture of my symptoms, upload that plus any other relevant clinical information that may be needed, and upload all of that through the EMR to the Rubicon specialist on the other side. That specialist is going to respond, take a look at my case, and respond within a number of hours on recommendations for care and additional guidance. And my Marathon Health provider can then incorporate that guidance into next steps, all while keeping me in the primary care setting and in the primary care relationship, which is where I should be. With this solution, we tend to see upwards of 25% of consults sent to RubiconMD, resulting in the avoidance of a specialist referral going out the door. This solution is live for our clients today. Yet we do know that there are times we need to refer out for primary care and support our patients in accessing that next level. This is where our value-driven referral solution comes into play. Within this solution, we partner with Garner Health to apply advanced cost and quality analytics on top of an existing health plan network that is already in place with the client: United, Cigna, Blue Cross Blue Shield, you name it. This allows for the selection of a specialist that is already within network, but has higher quality and lower cost ratings than their local peers, allowing for a more targeted approach to who that patient needs to go see in the network. We couple our data-driven approach with wraparound patient care and coordination support, ensuring our patients are supported every step of the way. Our referral coordinators partner with the patient on the selection of the specialist, appointment scheduling, and even ensuring follow-up results are given back to the Marathon Health provider and getting that patient back anchored into primary care. Again, like the specialty care avoidance, this solution, our value-driven referral solution, is also live for our clients today. And then as Nirav mentioned, as we move into 2025, we are now focused on the far right and deepening our approach by further strategizing how we can support our clients with the integration of a custom network. This is where a client is going to carve out specific episodes of care or services outside of that traditional health plan network and seek to pay for these in a different manner that is more cost-effective, whether that's a direct contract with the local system, a third-party vendor solution, or another model. In 2025, we are really piloting those different partnerships and models with our clients to further explore how we as advanced primary care can ensure effective uptake and use of these custom networks. We recognize that we as primary care are really the anchor for which referrals for these solutions should really stem from. I'm going to pivot a little bit with us as we move to the next slide and talk a little bit about our GLP-1 solution. But before doing that, we have another poll we want to put out for the group. So the first, how many times have you been asked about a GLP-1 solution in the last year? And then number two, are any of your clients struggling with a GLP-1 solution? We'll give it a few more minutes.
And this seems to hit a hot button, that's for sure.
All right, at 62% participation, again, what we're seeing is that for many of you, you've been asked more than 10 times about a GLP-1 solution, and many folks are struggling with that solution in general. Again, GLP-1s is becoming the popular kid on the block and the hot topic to talk about. And we've seen that with Marathon Health as well. We're seeing the need for that weight management solution or that weight management benefit on behalf of an employer continuing to grow. As with many of you, we're seeing it from an employee health perspective and outcomes that we know employers want to drive in employees, as well as creating a sustainable financial model that employers can offer and sustain that with their employee populations. And interestingly enough, we're also seeing it pop up from an employee engagement perspective. We've been tracking this in the market, and a couple of interesting market data points are coming out. One study with employees noted that 2/3 of employees that were surveyed noted that they would stay at a job they didn't like if the employer offered GLP-1 coverage. Another survey noted that 20% of employees would likely take a new job if that new job offered GLP-1 coverage. And so we're seeing this trifecta of a complex challenge coming to the table. And across our client population, we're seeing the question of coverage or the question of a weight management solution is becoming less of a question of if an employer will need to consider that moving forward, but rather more of a question of how and when an employer can implement that sustainable solution in a manner that addresses that trifecta: employee health, sustainability with rising healthcare costs, and employee satisfaction and engagement. And at Marathon Health, we've taken that complex problem seriously, and we're pleased to announce our newly launched GLP-1 Utilization Management Program. This program is part of our Level Up product line, a suite of solutions focused on certified health coaching, nutrition services, and advanced management of populations with a chronic condition. As you see here, within our solution, we have the ability to source medications directly at competitive pricing. That pricing can result in savings from up to a couple $100s per year per patient to upwards of $5,000 to $6,000 a year in savings per patient. We can implement a pre-authorization program that allows for a more refined and targeted approach of a GLP-1 medication use for weight loss that really focuses on that highest complexity and highest risk population receiving that most costly intervention. And we can deliver an evidence-based lifestyle management intervention that focuses on both nutrition and behavior change, whether as a standalone, as an initial opportunity for a client, or as part of an overall program solution that includes medication. A couple of key differentiators within our solution include the ability to provide that comprehensive approach on top of advanced primary care, keeping that patient solidified with the Marathon Health primary care provider. The effectiveness of a solution for GLP-1s should really be driven by primary care, and we at Marathon Health and our advanced primary care model are really positioned well to achieve this. We have the ability to require deprescribing as part of our pre-authorization process, ensuring that a patient that goes on medication is equally brought off medication when key targets are hit. And we have the ability to provide gatekeeping either at the Marathon Health level or at the level of the patient, where there can be a requirement to engage in lifestyle management prior to medications becoming part of that intervention. As you see here, our solution is comprehensive, but it allows for customized pairing of options for our clients. We recognize that a one-size-fits-all model doesn't work because clients are coming to the table at different points on the spectrum in terms of addressing that trifecta of employee health, financial sustainability, and employee engagement. And so our solution allows a client to pick and choose the combination of items that reflects their own unique timeline and what works for them. And with that, I'm going to go ahead and turn it back over to David.
Well, if I can get off mute, then you will turn it back over to me. No. Krista, why don't you just stay on for a moment, because we continue to get a lot of questions about the GLP-1 program, such as, can I do this standalone? How do I get started with it? Can you just put some additional parameters about what's a next step if either the consultant has a client with us or if someone's looking at a more complete solution?
Sure. So in terms of that first question of a standalone, our solution is building upon our advanced primary care model. So again, as I think Nirav and Jeff both articulated well, and I welcome their input in this space, the real key to solving and providing a solution to our GLP-1 challenge in the United States is going to be anchored in our advanced primary care model, and it should be. And so we do not offer a standalone solution. That solution is part of our advanced primary care model. And so the first step, if you have a client that doesn't work with Marathon Health as of today, I think the first step would be reaching out to the appropriate member of David's team to start that discussion of what that client is looking like, what might be the best path forward. If you do have a client that's working with Marathon Health as of today and would like to explore those next solutions, I would first start with that client reaching out to their client account manager to start that next step of that solution consultation and where that client may be in terms of the struggle or what that problem is we're trying to solve with GLP-1s. Again, I think it's becoming more of a question of when and how a client is having to consider a weight management solution rather than an if, because this part of our world in healthcare is continuing to grow. But our goal is to really walk along that path with our clients in a way that reflects what they are looking to solve for with their employee populations. I've seen everybody come on the line, so it's nice to see you all. But I wanted to make sure that I turn it over to Nirav and Jeff as part of some of those basic questions and really our advanced primary care model in general.
Thanks, Krista. I'd like to just bring to life why it's important to integrate weight management into the primary care setting altogether. So for example, right now nationally, if you look at the data on GLP-1s, 60% of people who start them stop them within a year. And the primary reason for stopping is side effects, typically GI side effects. When this is when it's not just a stranger on the phone, but your trusted primary care provider helping you start this, we know, for example, we co-prescribe Zofran, something that helps with nausea, when we start this to smooth the entry into taking the medication. Because we're following regularly for the 15% or so of folks who are non-responders, we know to stop it sooner rather than while you'll respond or maybe the next month. And then the people who do choose to leave, having that safety net of a health coach or a registered dietitian who's going to catch you and continue to help you work on the lifestyle changes, hopefully you were successful making while being on it, is what leads to the long-term durability of the effect and not just the sugar high you might get from being on it and then stopping it.
Jeff, I know you have thought a lot about this and spent some time on it. Most are worried about cost. Some have started, some of the clients have started a program and said, wow, that's expensive. What's your solution, or how do you think we can help with some of this?
Specific to GLP-1s or?
Yes, yeah, or medications in general. You could talk about that whole area.
Yeah. I mean, GLP-1 is obviously the category of specialty medication right now with sort of the highest demand, and also probably some of the, if properly used, the biggest opportunity to make a lasting impact. I think our view is unit cost is really challenging to manage. And so the real opportunity is sort of utilization management or proper use. How do we make sure that the right target patient that has the highest probability of a positive impact is getting on those medications? And to Dr. Vaccaria's point, like in a comprehensive or integrated program, overall lifestyle management, behavior change, and then really good clinical care kind of alongside the GLP-1 therapy. So I think that's the role that we can play, is to make sure the right people get on and see benefit and then adjust as necessary. Because the potential cost savings on the other side of the house here are significant. If you have, the right patient that's getting benefit from the GLP-1, then there's all sorts of downstream opportunities that can be impacted, whether that's just reduced hospitalization, advanced specialty care, future procedures, and then really bad outcomes, including death. So I think that's where we think that there's a role to be played, and probably the biggest opportunity.
That's fantastic. Jeff, we had a question, if you just wouldn't mind, or Narav, at what BMI do you find that there is a return on the investment?
Short question,
Nothing that's
but-
too
but a
hard for
big
you,
one.
right? Yeah, right.
So when used primarily for weight management and not for any comorbidities, we're typically looking at, based on the client's needs, certainly a BMI north of 30, sometimes it's 35. And then the savings that you would see are longer term in terms of, for example, reduced musculoskeletal spend. In fact, one of the studies that was being done specifically to look at the impact on arthritis and the need for knee surgeries was stopped early because within 3 years, they were seeing significantly improved rates on the GLP-1 population than not. Where you see more benefit faster is when patients have comorbidities, specifically diabetes, heart disease, and chronic kidney disease. GLP-1s also have been proven to slow the progression, if not reverse some of those. And that's where within 2 years, you're typically seeing from the pharmacoepidemiology studies, a positive return, again, when used on the right population.
Wow, that's fantastic. Nick, we had some questions about networks and how they work and how if you're a good candidate, if the consultant has a prospect that might work for a network.
Sure. Yeah. So as we mentioned, we have network locations in the Southeast in Richmond, Charlotte, and Orlando. And networks work really well for when you have a distributed workforce across a metropolitan area. And we have over 100 network locations nationwide. And what's great about that, so if you have employees in multiple locations throughout a geographic area where we have network solutions, or if you have smaller employers that typically wouldn't be able to support a traditional on-site, that's typically where we see the network solution being a good fit. And as I mentioned before, the great things about the network is, we're doing that build out ourselves. There's no capital costs for the employer in terms of building up that health center access, and they're built out in the community. So it's great access points for not just the employees, but also spouses and dependents. So they're in more retail inspired locations where you can get a lot better utilization from those spouses and dependents that are on the health plan, and not just at the workplace where it's easily accessible for just that employee that works in a location. It makes it a lot easier for the whole family that's on the plan to access. And the way we do that is we have a PMPM that we have as an access fee for those members that are accessing the network health centers.
Yeah. Shannon, one came in that was talking about Occ Health. Do you see Occ Health in some of your health centers that you're talking to consultants about?
Yes, absolutely. I'd say it's probably one of the most sought after requests that I'm seeing throughout my market lately is the integration of having a health center that operates for both primary care as well as occupational and even workers' comp needs. And so more of the clients I'm working with are recognizing that tackling those cost drivers on both sides is a fantastic idea to do within their health center that they place. And we can handle all of that. We have great experience with it. We, as you saw, serve quite a few large manufacturers across the country who are very heavy in the occupational health and workers' comp space. So we're accomplished at designing a scope of service, the right providers, making sure they're all certified, the right equipment that you'd need. And those equipment changes depending on if you're serving firefighters and EMS and doing fit for duty type physicals versus you're a manufacturer, maybe a tire manufacturer, and you need other types of equipment. So please feel free to reach out to us and we'll help design that center specifically around what your needs are for both primary and occupational needs.
Hey, David, if I could just maybe add one follow-up to the network question that Nick hit on. Because as he said, we have existing capacity and locations in Richmond and in Charlotte and Orlando. But I think for this audience, it's also helpful to understand we have, as more and more demand and interest bubbles up, we have then a number of emerging markets throughout the Southeast. And you can think about the larger metros, but sort of the more obvious ones where we have even early stage or more advanced activity now, the DC kind of DMV metro area. I think about in North Carolina, Raleigh and the RTI region. I think about Atlanta, Charleston in South Carolina, and then kind of the obvious larger markets throughout the state of Florida, whether it's, Jacksonville or Miami, Fort Lauderdale, Tampa. So if you've got large organizations that you work with there that could be a single anchor that can help us sort of launch a new market, or maybe a handful, 3, 4, 5 kind of, mid-sized organizations, often that can be enough that for us justifies the deployment of capital and opening kind of a new market with that part of the offering.
That's great. That's great. We are going to send out a survey afterwards we would appreciate feedback and Jeff, if you want to, this is the team again, you see emails if you have questions or follow-up questions, please feel free to reach out. We'll be sending this information out to you. And Jeff, if you want to wrap us up.
Yeah, I just appreciate your guys' time today. As David kicked things off, we're in the relationship business. And I think we really recognize that a successful partnership with any employer, with any labor organization we work with, it's only effective if we can partner really well with all of you as consultants. And it's, the blocking and tackling of good relationships. So really seeking to understand, listening more than we talk, really trying to understand how we can help make you successful as you think about not only supporting existing clients, but maybe there's ways that we can help you from a growth point of view as you're thinking about creating some differentiation from maybe others in your community or your market. We really want to partner together in ways that ultimately drives forward just better health of the communities in which we all operate. So thank you guys so much for the great work that you do, and really appreciate it.
Thank you all.